So I'm going to be talking a bit about different approaches to alcohol withdrawal and medical management. And so here's our normal disclosure. So by way of brief introduction and background, at-risk and problem alcohol use or alcohol use disorders, incredibly common in the United States with close to 30% lifetime prevalence, and that prevalence is even higher when you look at settings like hospital inpatient and primary care, and has been estimated to be as high as 40%. So this is an issue certainly to be to have on your radar, to be talking to patients, particularly in those settings, about it. And among individuals who have an alcohol use disorder, roughly 60% will experience some level of withdrawal symptoms, normally on the milder end, but 5% will progress to more complicated withdrawals, such as seizure or delirium tremens, which are serious issues. And in the case of delirium tremens, potentially life-threatening if it's not adequately managed. So certainly important to have some knowledge about this issue in populations of patients that a lot of us tend to see. I'll be talking just briefly about physiology here, because I think being on the same page with that, you can sort of get some understanding about the different agents around medical management that are out there and why we might feel like those would be effective. Go through some of the DSM-5 definitions around alcohol withdrawal, give you a sense of that, and talk a little bit about assessment and triage frameworks that may help around decision making as to whether the individual in front of me with alcohol use disorder might be managed on an outpatient basis, or whether we think that a referral to a controlled environment like hospital or a dedicated detox facility might better serve them. And then I'll talk about the different treatment approaches by way of the medical management. So in perhaps somewhat simplified version, but I think one that helps get us to some understanding around what works here, this is a brief bit about the physiology and action of alcohol. So it achieves its subjective effects through a GABAergic mechanism and is a depressant. The GABA is a primary inhibitory central nervous system transmitter. Glutamate is reduced with the acute effects of alcohol. That's a primary excitatory neurotransmitter. And opioids may be involved in the final pathway around the rewarding effects of alcohol. And in this setting of long-term use, their deficit may be in part responsible for craving. So those are acute effects with an episode of use, but with chronic daily consumption, then what happens is this calming GABA system centrally is down-regulated because the heavy daily alcohol consumer is providing this outside or exogenous source of calming effect. So in an effort to maintain balance or homeostasis, that system is down-regulated. The glutaminergic, the glutamate system is up-regulated. So once those physiological adaptations have occurred, if somebody dramatically reduces or abruptly stops their use of alcohol, you get this relative excess of excitatory glutamate activity and perhaps dopaminergic transmission, and that's what leads to the symptoms and the signs of alcohol withdrawal that we see that I'll be getting to in more detail here in just a minute. So we've gone through DSM-5 diagnostic criteria for use disorder previously, so I won't belabor the point here. Again, a use disorder diagnosis is made if an individual has been engaging in maladaptive use of a substance that results in repetitive consequences in 2 or more of these areas over the course of the last 12 months, with these first 2 criteria that I've highlighted with the bracket: tolerance for withdrawal, indicating physical dependence. Tolerance, again, meaning need to use more to achieve customary effect or achieve lesser effect with customary use. Withdrawal, meaning, as I've already alluded to, experiencing typical withdrawal symptoms upon reduction or cessation of use. That criteria can also be met, however, if the individual is continuing to use in order to avoid experiencing the symptoms of withdrawal. And then these remaining criteria around repetitive dysfunction attributable to use refers more to areas around indication of engagement in compulsive use or loss of control over their use, inability to cut down, giving up other normally rewarding activities, failing to fulfill obligation, things along those lines. DSM-5 also has specific criteria around alcohol withdrawal, and of course involves a period of heavy daily consumption and then cessation or reduction of that use, and experiencing 2 or more of the symptoms you see listed within hours or days of that abrupt reduction or cessation. So this increase in autonomic activity or sympathetic activity, where we see increases in heart rate and blood pressure, sweating, anxiety, tremulousness, sleep-wake cycle may be disrupted, nausea, vomiting, and as things progress into more complicated forms of withdrawal that I'll talk about a little more in just a bit, we see different forms of hallucinations, seizure, and delirium. And these are some of the syndromes that we typically will refer to as more complicated forms of withdrawal. So forms of withdrawal where you're not just seeing evidence of autonomic hyperactivity, not just seeing anxiety and high blood pressure, high heart rate, for example, but also seeing phenomena such as hallucinoses. And in the setting of alcohol withdrawal, these are most commonly visual, and visual hallucinations commonly involve animal content. Next most common would be tactile hallucinations, commonly what's called formication, or the sense of crawling over the skin, followed by auditory hallucinations. Command hallucinations, however, say auditory hallucinations telling the individual to harm themselves or others, are actually quite uncommon in this setting. Alcohol withdrawal seizure, most have likely heard about, tends to occur within 24 hours after a last consumption of alcohol in those at risk or who would experience it, and is always a generalized seizure or convulsing throughout the body. There are also seizures known as focal seizures, where you may just see part of the body moving, or what's called an absence seizure, where they're detached from the world around them. And those other forms of seizures are not alcohol withdrawal seizures. Alcohol withdrawal seizures are a generalized, all over the body kind of activity. And then, of course, one of the more complicated withdrawal syndromes is delirium tremens, or DTs, where the individual is disoriented, sometimes combative, agitated, most frequently accompanied by fairly severe evidence of fairly severe escalation of autonomic activity, like the heart rate and the blood pressure and things along those lines. One thing I'd emphasize in saying DTs is if you ask a patient if they've had DTs or they mention having had DTs, I think it's always important to clarify what they mean by that. Because when I ask a patient what they mean by DTs, I've sometimes heard folks say, oh, when I get up in the morning, I feel shaky and I need a drink. As many of you, if not all of you, likely know, that's not DTs. DTs is, again, that syndrome of disorientation, agitation, confusion. I've already alluded to this, that the delirium may be accompanied by hallucinations. I mentioned the autonomic hyperactivity, agitation, disturbance of sleep-wake cycle, where they may be more likely to be more active at night, generally peaks at 3 to 4 days after a last consumption, and can last weeks, even though more typically 5 to 7 days. So far as some things to think about as we're considering whether an individual might require hospitalization or a dedicated detox facility as opposed to managing their withdrawal on an outpatient basis. The prediction isn't perfect so far as who will progress, but there are some things in the literature that let us know about factors of greatest risk for progressing to, say, seizure or DTs. Primarily, as you might suspect, individuals who have had an alcohol withdrawal, seizure, or delirium tremens previously are among the folks at highest risk for experiencing it again. So important to gather that piece of history. Higher withdrawal scores early may also be predictive. I'll be talking a little bit more about that CIWA scale for those not familiar. Serum electrolyte abnormalities, the most common of these being magnesium. So important to assess that. The extent of magnesium depletion has been related to the severity of withdrawal in studies in the past and can be more difficult to get under control if that isn't corrected. So important to have an eye out for that, among other things. Individuals with more serious medical comorbidity may also be at greater risk for withdrawal. An elevated mean cell volume is a marker of malnutrition, has also been predictive in the past. Another thing I always keep my eye out for if they've presented to emergency departments or been hospitalized in the past is what sort of blood alcohol level have they achieved previously. And if I see that they have been greater than 300 milligrams per deciliter or level of 0.3, particularly if they've still been able to give a coherent history and interact with folks, that demonstrates a quite high level of tolerance and is someone who's at greater risk for more serious forms of withdrawal as well. There's likely also a component of heritability or genetics that confers some risk around the sort of withdrawal and severity that an individual might have. Certainly an area of research now, but not something that's typically getting used in clinical practice to assess risk along those lines. So when managing outpatient, there are a variety of potential approaches. Scheduled benzodiazepines are commonly used, and I've put up just a couple of examples of what that might look like. There is some room for practice variation along these lines. Chlordiazepoxide or Librium, you see an example regimen that appears here. This is one of the very long half-life benzodiazepines, so akin to diazepam or Valium along those lines so far as having a very long half-life. A characteristic of chlordiazepoxide as opposed to diazepam is that it's less lipid soluble, so it penetrates the central nervous system or brain more gradually than diazepam does, and some have felt that characteristic of diazepam may make it, if used on an outpatient basis, more rewarding or perhaps more difficult to control for someone that has a use disorder, particularly for someone with an alcohol use disorder where there may be some cross tolerance with benzodiazepines. I've also put up a sample regimen here for lorazepam, and that's an agent that we'll often look to in this population who has risk for liver disease and difficulty with metabolizing these longer acting benzodiazepines that have more active intermediate metabolites. So lorazepam is a potential option there. Some of the anticonvulsants or anti-seizure medications have also been studied that I put up here, including carbamazepine and gabapentin. Regimens, different regimens have been studied and vary to some degree. So I've put up a couple of examples here. Gabapentin, incidentally, in a randomized controlled trial, has been compared head-to-head with lorazepam and was similarly effective in terms of withdrawal scores if you get to this therapeutic range that you see out here. There have also been some symptom-triggered regimens studied where patients are given a sheet that guides them in scoring the severity of their alcohol withdrawal and can be given some guidance around the sort of dose of medication to take based on that subjective withdrawal experience. But don't know if that's super typical practice yet. In the inpatient setting, Evidence really pretty clearly tells us that symptom-triggered kinds of regimens are preferable. They tend to reduce duration of hospital stay. They also tend to reduce the amount of sedative or benzodiazepine that is given to folks. So, and that's important. I don't think I have a mouse. Thanks. For those not familiar, I just was going to show you what this withdrawal scale that's likely most commonly used looks like to give you a sense of it. So the nausea, vomiting, tremors, anxiety, agitation, sweats. Oh, need to share it. Thanks. Tactile disturbances or hallucinations and things along those lines that generates a score that can guide the dosing. And in inpatient settings, most typically benzodiazepines, though, we're starting to see a bit more use of alternatives such as gabapentin and phenobarbital that I'll be talking about a little bit more here on the following slide. On this slide, actually. So the best studied agents, again, so far as controlling withdrawal and preventing progression to more serious forms of withdrawal are the benzodiazepines. There are some other adjunctive medications that can help with symptom management as well, including neuroleptics if someone is agitated or combative to the point where it's interfering with their medical care, for example. Anticonvulsants have been added on as well, and may allow for reduction in the symptom-triggered benzodiazepine dosing. In teaching our learners in the hospital, I'll always make sure to emphasize that they not to forget thiamine in this population, since its lack and administration of commonly administered glucose-containing fluids can result in Wernicke-Korsakoff's, which is an acute neurologic issue. So I always make sure to emphasize that thiamine be given early and daily. Phenobarbital is starting to get renewed interest as well, and that was an agent being used for alcohol withdrawal decades ago, and then the evidence developed around symptom-triggered regimens with benzodiazepines. But there are getting to be more studies around the use of phenobarbital and thought about what its role might be. It certainly can be considered as monotherapy, particularly if someone has responded to that better than benzodiazepines in the past. It's also been studied in patients who have also been receiving benzodiazepines and maybe having a refractory course of withdrawal or given early. In the case of one study set in emergency departments, and that early administration was associated with lower rates of intubation and ICU admission. So that is something that is out there and that we may be seeing more of. Sometimes, despite our best efforts along those lines, individuals will proceed to more severe forms of withdrawal, particularly delirium tremens, which again is potentially life-threatening. And in individuals with it or who are combative, it may interfere with their care. So these are ways in which we can ramp up that care, including continuous infusions of benzodiazepines such as lorazepam. The polyethylene glycol vehicle can cause a metabolic acidosis. So if that agent is used via infusion at higher doses for longer periods of time, 24 hours or more, it's worth thinking about a switch to midazolam, which doesn't have whose vehicle doesn't have that toxicity associated with it. And someone who's progressed to this sort of withdrawal and requires this level of management, we generally recommend to primary services to titrate those agents so that the patient is lightly sedated, still protecting their airway, but will arouse to name or light touch, and maintain that level of sedation for a period of time before considering titrating downward, say 2 or 3 days. Already made mention of adjunctive neuroleptics, again, which don't treat the alcohol withdrawal, but which may assist in sort of behavior management if agitation is interfering with care. We're also seeing a lot more use of adjunctive dexmedetomidine or Precedex, which is an alpha adrenergic antagonist agent that can provide some sedation, calming effect. Does not provide seizure prevention, so we always emphasize that the patient should be receiving sedative as well. And then severe cases, we have seen folks progress to the point where they need to be sedated and intubated because withdrawal is so severe and its manifestations are really interfering with their care. So that's what I had to cover today by way of some of the approaches around medical management of alcohol withdrawal. It's incredibly common, particularly again in hospital settings, and so something to watch for. The more severe forms of withdrawal are potentially life-threatening. Early management can reduce hospital days, and the risk and symptom-triggered regimens are best at that. And then for our learners, I know I'm preaching to the choir here, but I always remember to emphasize that the detoxification isn't treatment for the alcohol use disorder, and it's important to develop plans around disposition so far as facilitating the recovery from the use disorder itself once the withdrawal has been adequately managed. So.